Welcome to the Healthusiasm podcast, a panel discussion on trends and innovations in health and self-care. My name is Christophe Jauquet. I'm the author of the Healthusiasm books and a professional keynote speaker on health, business, and technology. Every week, I discuss with a panel of experts the positive changes that are shaping our health and happiness. And for this discussion, we have a full panel. Calling in from Barcelona is our digital health connector, Aline Loiset.
Hola.
From Scotland, but living near Brighton, medical expert in digital innovation, Dr. Keith Grimes.
Hello, everybody.
And last but not least, from Ghent, Belgium, human experience expert, Mo Zouina.
Hello.
Ready for a good session today, guys?
Ready?
Yes, looking forward.
Very much so.
Because it will be an interesting one. In this week's episode, one of the panelists will bring a trend or an innovation forward that sparked their healthusiasm. And the rest of the panel will then debate and share their opinion about it. Do they find it something, nothing, or everything? And more specifically, we'll be talking about innovation in cancer. But Dr. Keith Grimes, what sparked your healthusiasm around this month?
So, thank you. Cancer is an important topic. And there's often things in the news, but it's nice to focus on some positive changes here as well. And, why talk about cancer? Well, the statistics are obvious. 1 in 2 of us will be diagnosed with cancer in our lifetime. It's going to affect, if not you, the people that you know. 18 million cases per year globally, 10 million deaths, lots of common causes that we all know about. So this is a really big area. And the issue was that the pandemic has put a big backlog in place. So we're struggling with a lot of burden and things to catch up on. So we're really keen to see some new solutions. And the Healthusiasm this week, the interesting thing was about a study called the Perception trial. So published this month in Nature Cancer. Perception stands for Personalized Single Cell Expression-Based Planning for Treatments in Oncology. So what does that mean? Well, the personalized means taking treatment and personalizing it to the individual. The single cell expression talks about how cancer cells express different proteins on the outside, and that helps you determine what drugs to use. Now, cancer is not just one disease. It is many, many different diseases, often in one person, lots of different causes, and there's lots of different treatments. Traditionally, those treatments would be quite broad, treating the whole body. Chemotherapy, radiotherapy, surgery to take out an affected part. But over the last few years, we've seen increasing personalization. As we know more about cancer, we can find new drugs that target very, very specific areas. So the question is, well, what drug do we do? So we take samples of the tissue and sequence them, and then we can find out what's going on and we can choose that. But when you've got so many drugs and so many different things going on, how do you match this up? Enter data science and artificial intelligence. And this study actually looked at how this one way of judging how the cancer cells are growing, how they express targets, is run against big databases of drug performance against different types of cell expression. And then the technology was used to predict, well, which of these drugs or which of these drug combinations is going to be most effective at this time for that patient. And the trial looked at myeloma and breast cancer and showed some really positive effects on improving outcomes. And this is a theme that's developing in cancer. It's functional precision medicine. And late last year, I went to an event where they were talking about some of this. It was called Disrupt Health Tech. And I heard from 3 people, someone called Duleek Ranatunga from Pear Bio. And what they do is they take tissue samples, make multiple micro tumors. So you got lots and lots of different micro tumors, which you can then run lots of tests against. And then they use AI and computer vision. You put the drugs in and you can see which drug is effective before you put it into the person. And that's really important because you want to get this right the first time. Cancer moves fast. Or how about there was someone called Laura Tower at Vivan, and Vivan do something a little bit similar. They take the tissue and they try and make multiple copies. But guess what they make the copies in? Fruit flies. They put these genes and they have hundreds and thousands of different genetic variations put in the fruit flies, which they can then expose to different drug combinations to work out what you need next. And then finally, the most impressive thing when I was in there was a doctor called Michael Castro from the US. And he talked about the importance of when you're treating cancer, you can't just treat one area, you have to treat the combinations. And as he was describing this, he talked about a case of a younger woman from Holland, I believe, or the Netherlands, pardon me. And she had malignant glioblastoma, I think it was a neuroblastoma. Essentially, she was in terminal care. By undergoing special sequencing and really concentrating on the combination of drugs, some of which are not very common, he was able to treat her. And in the talk, he said, and here's a photo of her completing the marathon last month. We were all very impressed because, of course, this woman was on death's door. But then he said, oh, and she's also in the room. And she stood up and waved at us. And this is something that is almost universally fatal. And she is standing up in front of us. These techniques are incredible. And AI and genetics and our understanding of how cancer works is opening it up. But the problem is it's extremely expensive. And one of the things that'd be interesting to sort of open up for the discussion is how do we celebrate these new technologies, but make them accessible to people? So I don't know, I'll hand it over to the floor. And what do you make of all of this, the changing nature of how we treat cancer?
Who wants to go first there? It's really an open floor you're putting out there.
Yeah.
Well, I think the entire domain is being redefined, but I totally agree with you. Do we have the means of our ambitions? We've also seen, for instance, how big is the increment in which you improve that, right? So I think with precision comes premium. And there's one thing that is limited. It is resources, right? So maybe we should have AI define what the best option is, where the balance between effort and cost is optimal.
And
I think that is the next challenge. It's the decisional inertia. It's not just to tell you which treatment combination is better, but which output is the best between effort versus outcome. Because effort means people, technology, investment. So let me give you an example. One of the companies I worked for was Biomed. It's now Zimmer Biomed. And they kept on, and they do prosthesis, a new knee, a new hip and things like that. And they kept on inventing new coatings and things like that. But they came at a premium in which and I'm sorry to say that, a life has a monetary value. It has been defined, Keith. A life has a monetary value. And they said, and in the Scandinavian countries, they say, I think we're getting more value out of the base model of the hip implant, right? Because the premium you're asking. And then it's a vicious circle, because if you pay for the base model, you don't fund the innovation of the life science company. So it's stuck between a wall and a hard place. But I think having a good balance between the incremental value in terms of outcome and the relative effort, being it human or financial, is the new frontier. Because we'll have lots of ideas, but I think we need to make balanced decisions there.
But I mean, to jump on that, I mean, today the cost of an oncology treatment or a cancer treatment is way bigger than a human value. So the reimbursement for oncology treatments is accepted exceptionally just because it is, such a daunting and life-changing disease, and it impacts people mentally as well. But the cost is always we're talking collies here. I think it's called collies, and I think the cost of a life is 40,000 euros a year. It's 40,000 euros.
Yeah, it's quality adjusted. It's quality adjusted life years. Quali. Yeah.
And so the cost of an oncology treatment is way beyond what normally should be approved for reimbursement. So we're already in that situation, and I think any additional, innovation in that regard needs to come out at a way lower cost to be able to. And we're definitely not there yet.
It's we can see what the market does to this. They come at a premium, and over time, efforts are made to reduce the cost and spread it out as well. But, this is about, in some ways it's making decisions at a population level, but then at the personal level, please spend whatever money it is to have more time myself or with my family and so on. But, Aline, from your perspective, what do you make on this sort of big disparity, potentially great advances that come at such great costs?
Well, I think there's like many things coming, many really cool innovations that will really make a difference. And we've already discussed a few in this podcast, like nanorobots or solutions that are being tinier and tinier that can really target the cancer or the tumor where it is, no? But related to your point on link between treatment and cost, I was at a conference in Basel recently, the Boom conference, and there was a same presentation on why companies failed or didn't work. And I find it interesting because they used the case of Proteus. Like if you remember, Proteus was that pill with a sensor included in it. You can just swallow it and you
was the drug.
follow. Exactly. And they actually did a clinical trial for colorectal cancer. And that actually didn't really work because although that was an innovation and you can see if the patient was taking the pill, how it was affecting when it was being digested into the body, how it was affecting the body, if the treatment was efficient or not. But the cost of that treatment was actually superior to like a normal chemo treatment. So that's why it didn't work, because the business part of it, who pays for it, is always an issue. And I thought I didn't really think about that use case in that way, but I thought that was very interesting. No? And maybe an example also that I found very insightful last year, I was at MD Anderson Cancer Center in Houston. And it's like one of the flagship cancer center in the world. And we had a very interesting a clinician there who are working on cell therapy. And they were presenting what they're doing there. In fact, it was really amazing to see how just like one single dose treatment can actually improve and like completely reverse cancer. So there were cases of kids, especially in that case, that were young, but they were cancer free for like 2 years, 3 years, or cancer completely gone. But again, this has a cost. And as we were saying before, this is amazing, but who can access those treatments today? But I think it's going to be like the DNA. If you take like DNA sequencing, it was very expensive, and then it decreased a lot to the point that today consumers can access it. So I would expect something similar around the cancer treatments.
Yeah, you'd hope so. Mo, sorry, you have some thoughts.
I think we also need to be really realistic at the forces at hand. Who would benefit from cheap cancer treatment? Imagine there would be a treatment that would really be cheap. Let me give you an example. If you can, please follow Zach Bush, MD, who at the basis was an oncologist. He found a treatment, a vitamin A compound that was incredibly good at treating cancer. And a pharmaceutical company patented it just to have it so that it wouldn't be released. So
catch and kill.
Catch and kill. Yeah, right. So anything that would devalue our current business model, we'll just own and put it literally in the freezer so we can keep. And it's a vicious circle because we all want shares that do well and people invest in life science and everyone is working on the stock market and things like that. So I think there's also the forces at hand. Who would benefit? And I think there are things in the cupboard that could outsmart, the Pareto rule, that could have 80% of the efficacy for 20% of the price. I think they're out there, but we just don't know about it.
Well, do you know what's interesting? I think you're right on this. And actually, I mentioned Michael Castro earlier on, and part of this kind of drug cocktail of approaching cancer as a number of different pathways, and you have to take them all out. You can't just take one because it'll work around it. Some of the drugs were very low cost. It was metformin, a common diabetes drug, vitamin C in large doses. And this isn't fringe science stuff. This is core, well evidence-based science, but used in combination. And I think, you hope that what you're describing doesn't happen that often, but I can totally imagine that it does. My hope is that by pushing the tools to be able to make these decisions out to the people, it makes things easier. And actually, to that end, the article that I talk about, you can download the repo to do the work from GitHub, as in you can just download the software to run this yourself. And so once again, the benefit of people having access to their own data to allow them to make informed decisions and work with healthcare professionals to do this would be good. Mo?
Maybe we can evolve towards an open source health system where the best combinations are kind of shared. And
now you're dreaming.
I don't know.
That's good.
I'm just putting it out there. A value model, open source, So I think the only way forward is to scale it at a cost that is affordable, and maybe we'll get a billionaire who just does it for the fun, right?
Yeah.
Somewhere.
Christophe,
Christophe, go, because you worked at Pfizer.
I was responsible for a whole lot of oncology drugs indeed, but I'd like to make things a little bit more complex, definitely when it comes to the money side of things. Because one, we know there's a number of people who are diagnosed with cancer and the drugs are pretty expensive. But two, there's some pretty amazing innovations in the market right now that can detect cancer pretty easily and pretty fast or early. And one of them is GRAIL. I don't know if you heard about it. They have the Galleri test. It's a blood sample test, and they can cancer a lot of, I think about up to 50 different cancer types at once, which is pretty amazing, because what they've noticed is that the earlier you do it, of course, the higher the chance of survival, which then turns, as you were introducing it, the topic with Keith, which turns cancer into a almost perhaps chronic disease. The thing is, we're not there yet. It's very early. I mean, it's on the market. You can buy it. It's about $1,000. So it's not exactly for everyone. It's not reimbursed yet. They originally in the US, they wanted to have it reimbursed by 2024, 2025. Now it's pushed back to 2027. But I think we're going into the direction where one day it will be a routine for everyone, maybe for everyone at risk for sure. I really like that example. The other one is not a blood test. It's a full body magnetic resonance imaging system. It's a new startup, which is called, relatively new. I mean, it's new to me at least. It's called Ezra. And you can actually have about 13 different organs scanned. And it costs about $1,350 for 5 to 6 organs, and then 2,000 euros for a couple more, and then 2,500 for the lungs included. So again, super pricey. It'll help to diagnose cancers way earlier, but it comes at a cost. It's not for everyone. It probably will be very hard to have it reimbursed, because why would the government, to your point, Mo, why would the government want to reimburse it that easily? It would only increase the cost of the healthcare expenditures even more, because we will know when people have cancer more early. There will be a lot more people with cancer. There will be need for more reimbursement, longer time reimbursements, etc. So it's almost a non-desirable situation for governmental budgets, let's say.
Yeah, it's so interesting to think about the finances. Sorry, Eileen, maybe you've got a point to make here.
Yeah, exactly. So what I find interesting to your point, Christophe, so there's different solutions who can detect like cancers earlier. And we have the example of a solution here in Barcelona called Sikai. And one of their first use cases was pancreatic cancer. And we know that's like one of the deadliest one today. So they said that they can detect it earlier. But the thing is that to detect it, they detect it on X-ray. So they actually analyze different X-rays and they see the evolution. It means that people have to do the X-ray. So I think, how do you make we don't usually do X-rays, right? So how do you make that first X-ray? So it's efficient if people are doing X-ray. Otherwise, it's not really. But that's a cool thing.
That's the cool thing about the Ezra, because it's a full body magnetic resonance. It's MRI, which is less unhealthy. So X-rays, I do agree.
Yeah, but how often would you do that? Even the blood test that you were mentioning before, and it does a cost each time. No, how often do they recommend to do a full body scan?
I know somebody personally. He's 85 years old, and for the past 30 years, he's been doing it every year, like a full body scan. I mean, he's a millionaire, but he does it every year.
To have started out as a billionaire. Yeah. No, it is interesting. I just want to sort of flag one thing. You know, it's really exciting, these ideas, but there is a kind of natural law at play here, rather just simple maths, is that with screening such as these, you know, none of these are going to be perfectly accurate, sensitive, or specific. There'll always be false positive and false negatives. And in a world where some conditions have low prevalence, they're not common, in the population. The truth is that by using these technologies, regardless of how good they are, you will, in some cases, turn up more false positives, which require investigation, sometimes costly, painful, dangerous, if it's a biopsy. So we have to be a wee bit careful about this. I'm not saying we shouldn't pursue it, but there's always this, if you have a full body MRI and they say, oh, there's this tiny little node in your lung. It's right next to the carina. It's right next to the heart. What we need to do is we need to do a biopsy of it. So we're going to take you in and we're going to stick a needle right next to your heart to take this, or we can leave it be. It's probably nothing. Do you feel any better at that point that you've got this sort of sword over your head? But we'll have this sort of moving line, won't we? One other thing I wanted to say about this, and it's an interesting one, is that you can also flip this a little bit. And we talk about AI helping out with the diagnosis. We just talked about that. But this week also, Moderna, who are doing incredible things. This morning, just the phase 3 trial for their vaccine, personalized vaccine for melanoma came out. But Moderna have partnered with OpenAI, and they're using AI not just for things like drug discovery, but to just help with the admin inside the organization. And remember, a way that we can bring the costs down, if we're feeling optimistic, is by making the cost of doing business, the cost of creation, bringing it lower. And by using GPTs, these sort of small tools that you can build, they found a way to do that. So AI and technology can help on that side too. Mo?
There's also maybe a blind side we haven't seen. The fact that testing is lower we're lowering the threshold, right? Go and apply for a credit and tell that you've been tested for cancer, but it's negative. So there's also a thing. Have you ever been tested for cancer? Yes, but it was negative. Yes, but okay, good. Here's your interest rate. Here's your life insurance policy. Here's your premium on potential cancer care. Here's your out of pocket. So it also comes with a societal and also financial implication that is indirect, because if that is in your file, it has a domino of, employee recruitment and things like that. So do we have the means of our ambitions? And secondly, can we look beyond health and see what the implications are of testing more and more frequently? Maybe
to bring that to an end just now before I hand over to you, Christophe, as well. It's interesting. We may actually end up with the cure for cancer, but actually, on balance, it would be too costly to cure it, and it would be better to live your life with the consequences and not burden everyone around you with the costs. An interesting scenario to end up towards, isn't it, Christophe?
Yeah. And even that in itself could create a whole new business and support and services and innovations around it, which might even help us living and dealing with it for sure. Well, lovely. Thank you for this discussion. I would say it is clearly everything that's happening in the oncology space. Now, time for something else. And that is the end of the podcast, of course. Time to wrap up the Healthusiasm podcast for this week. Thank you for listening. If you like this show, don't forget to hit the subscribe button on your favorite podcast platform. You can also visit healthusiasm.com to discover the other episodes, subscribe to our newsletter, and learn more about our panelists. For now, I'd like to thank our panelists for their Healthusiasm. Thank you, Aline Noizet, Dr. Keith Grimes, and Mo Zouina. My name is Christophe Jauquet. We are the Healthusiasm panel, and would love to see you again next week for some more Healthusiasm. Ciao.